Okay, we are going to start our first PowerPoint on digestion, and I'm going to do this as a screen capture in case I need to use the pen and draw on this. So, when we talk about anatomy and physiology, remember we know that from the perspective of structure and function, digestion is really relevant in terms of structure and function because when we look at the mouth can really give us a lot of information in terms of digestion, in terms of what type of foods we should be consuming. And we know that in the mouth, because we got 32 teeth, there's mechanical digestion that takes place there. But in terms of where digestion starts, we have to talk about the brain, right? In terms of your thoughts. We know that many eating disorders start up in the brain. We know that you can smell grandma's cooking. And just through using the sense of olfaction, it can stimulate the digestive enzymes in terms of salivation, in terms of getting the digestive enzymes prepped in the stomach to break down proteins. Also, the hypothalamus up in the brain is involved with thirst and hunger and satiety. And you guys remember Pavlov and conditioning the dog, ringing the bell, and the dog would then salivate. So, digestion really involves the processes of taking these larger, complex foods and then breaking them down into smaller and smaller parts. And we call that catabolism, right? When you're taking the bits and you're using it to build up something bigger, we call that anabolism. So here we're taking proteins and we're breaking them down into amino acids. Or we're taking triglycerides and we're breaking them down into a glycerol backbone and 3 fatty acids. And fatty acids are carried into the mitochondria through an amino acid called carnitine. That ends up being the shuttle that brings fat into the mitochondria for fuel. And then we take these complex carbohydrates like starch and glycogen, and we remember that anything that ends in ogen is inactive, and glycogen is the inactive form of glucose, or glucose in storage. So it can break down glycogen into glucose. And we know that we can adapt to a variety of foods. There are certain cultures that can handle certain types of food easier than other cultures. Native Indians, for example, can handle smoked foods better than other cultures. There are certain cultures that can't handle dairy very well. Certain individuals can't tolerate and process the protein gliadin or gluten very well. But overall, if you look at the variety of foods that we can consume and what our bodies can handle, from nuts to seeds to animal-based products to fruits to vegetables, plant-based, and then things that we call food, you know, pretzels and Twinkies and Skittles and lollipops and donuts and cake, right? I mean, junk food, but yet the body can try and get something useful from that and extract it to try and use it for fuel. When we talk about food allergies can happen immediately, right? I mean, they can happen. Someone can have peanuts or peanut oil, and instantly their tongue can swell up and their throat can close up, their airways get restricted. But food allergies can also happen 3, 4, 5 days later. They can be this delayed onset type of reaction. And the delayed onset reactions, as you see below, can actually create decreased learning, decreased memory, hyperactivity. When you look at those 3, that's ADHD right there, isn't it? So things like, perhaps, why is it every Friday, someone may get a headache, and maybe it's from the meal they ate Monday. And maybe they always eat at the same restaurant, or they're always working in a certain or a particular environment every Monday, and then 4 or 5 days later, that individual's always having headaches, or they always have nausea. And it may not be anything that happened on Friday. It could be 3 or 4 days prior. So there's a variety of symptoms of food allergies, but really it's anytime you put a protein in the body or a foreign antigen that the body doesn't like, or any type of antigenic load, the body can react to it in a variety of ways. And there's always different antibodies that the body produces. Sometimes they're IgA, IgM, IgE, IgGs, and some of them are immediate antibody production, and some are delayed onset antibody production. The IgGs are delayed onset. The IgEs and IgAs are almost immediately produced. And we spoke about the gallstones and people that have gallbladder attacks being a reaction to food allergies, because when you put food in the body doesn't like, and it goes in the mouth, down the esophagus, into the stomach, and eventually those contents get dumped into the stomach, and from the stomach into the beginning of the small intestine called the duodenum or duodenum, the duodenal lining can start to break down because the inner lumen of the intestine is epithelium, and epithelium can break down. And when it does, whenever fat from the stomach is dumped in the duodenum is supposed to secrete CCK, which is cholecystokinin. And when cholecystokinin is released, that hormone goes to the gallbladder and makes the gallbladder contract. And when it makes the gallbladder contract, it secretes or releases all the contents that were in the gallbladder, one of which is bile. And the bile that the gallbladder secretes into the duodenum is produced by the liver. So the liver makes bile, which is a fat emulsifier. Means it breaks down the fat. It stores it in the gallbladder. Now the gallbladder contracts as a result of CCK, and it breaks down the fat. There's also cholesterol in the gallbladder. There's also toxins in the gallbladder. And there's also calcium in the gallbladder, and of course some water. If CCK isn't being released, then that means the gallbladder never contracts to release all of those contents, so that means you have stagnation. Whatever's in the gallbladder is stagnated. Now if you have calcium and cholesterol and water and phospholipids stagnating, you can get these stones that form, and these are gallstones. They're called cholelithiasis. Cholelithiasis are gallstones. And the next time the person eats something fatty, those stones can get trapped in the cystic duct or in the common bile duct, and you get this buildup of pressure because now you get a backup, and that person feels excruciating pain in the stomach, typically in the upper right quadrant of the stomach, which is where the liver is, and pain behind the right scapula and the shoulder blade. So then they'll have the gallbladder removed. They'll have a cholecystectomy. They'll have the gallbladder removed. And as a result, now they have to rely on the liver constantly producing that bile and constantly having this slow drip into the duodenum to break down fat. Not the most efficient, but it happens. That type of person needs a lot of assistance with digestive enzymes to break down the fats, the proteins, and the carbs. So they do make supplemental digestive enzymes and lecithin to break down the fat as well. When the solution could have been finding out what they were putting in their body that was this antigenic load that their body didn't want, and removing that irritant. Remember that 5R program, which is remove the irritant, replace with digestive enzymes, re-inoculate the individual with probiotics, repair the gut, and then rebalance their lifestyle. Those are the 5 R's that are used to help rehabilitate most digestive disorders. So let's go through some of the basic anatomy here. So we do have the lips, which are used to manipulate food and bring food into the mouth. We have the tongue. And let's think some of the cranial nerves that are involved with the tongue. We have cranial nerve 7. So if we write it with Roman numeral, that's 5, 6. We have cranial 7, which is the facial nerve. And that's for sweet, sour, and salty for the tongue. We have cranial nerve 9, which is the glossopharyngeal nerve, and that is for bitter, the taste of bitter to the back of the tongue. 9 is also involved with swallowing, the muscles behind the throat. We have cranial nerve 5, the trigeminal nerve, for pain and temperature to the tongue, and also muscles of mastication. So 5 is important, that trigeminal nerve. So we have facial nerve, which is 7, glossopharyngeal, which is 9. We have the trigeminal nerve, which is 12. And then we can't forget cranial nerve 12, which is the hypoglossal nerve, which is involved in moving the tongue. So you've got quite a few cranial nerves there that just deal with the mouth and digestion. Then we have right here these 3 groups of salivary glands. You've got the parotid gland, the sublingual gland, and submandibular gland. Then we have the esophagus, this long tube right here, which will bring food into the stomach. And the stomach has different portions to it. The top part right around there. Let me see if I can use a different color. Let's see if we can change it. Let me change it to blue for a second. So right there, this section is called the cardia, because where the esophagus and the stomach meet, the heart is kind of like right there in this area. So the cardia, you have the cardiac sphincter, also known as the lower esophageal sphincter, opens and dumps the contents of food into the stomach. The food in the mouth, when the body is breaking it down, is called bolus. And by the time that food hits the stomach, now it's called chyme, C-H-Y-M-E. The top of the stomach right here is called the fundus. And then right here you have the pyloric portion, and you've got the pyloric sphincter. And then we have the small intestine, which has these 3 parts, DJI, duodenum, jejunum, and ileum. The jejunum makes up the largest portion of it. Duodenum is the beginning portion, and the ileum is the lower part right here. And the ileum connects with the large intestine, where we have this section of the large intestine called the cecum. The cecum means blind pouch. And then we have the ascending colon, and then we have the transverse colon, and then we have the descending colon, and then we have the sigmoid, the swirl, the S, swirl and S for sigmoid, and then you have the rectum and the anus. The accessory organs would be the liver, the gallbladder, and the pancreas. There's the pancreas right here near the stomach. Okay, pancreas is not just involved with blood sugar regulation, where you have alpha cells, beta cells. There's also delta cells and acinar cells. Beta cells are for the islets of Langerhans, produce insulin to lower blood sugar. The alpha cells of the islets of Langerhans produce glucagon, which goes to the liver to break down glycogen so that glucose can be gone, meaning glycogen gets broken down into glucose, and now glucose is released into the blood to increase blood sugar. So you got the alpha cells and beta cells doing different things in blood sugar regulation. Beta cells produce insulin to lower blood sugar. Alpha cells release glucagon to increase blood sugar. The acinar cells are involved with the digestive enzymes, like pancreatic lipase, pancreatic protease, pancreatic carbohydrase, and and also sodium bicarbonate, which is an alkaline or a base that's used to neutralize the acidic pH of whatever is being dumped from the stomach into the duodenum. Now you've got the pancreas releasing this alkaline solution into the duodenum to buffer it, as is the gallbladder. So you have both the gallbladder and the pancreas releasing something that's kind of like high in pH and alkaline to buffer out the acidity that's being dumped into the duodenum so you don't get a duodenal ulcer. Okay, you can see that a lot of absorption, especially water absorption, takes place in the small intestine. Okay, so there's a lot of absorption that's taking place in the small intestine. The large intestine is really where a lot of the bulk is formed, where a lot of the stool is formed, but in terms of digesting and absorbing the nutrients that's pulled into systemic circulation, whether it be the lymph or the blood vessels, that's going to take place in the small intestine. There's a lot of chemical digestion that's taking place in the stomach. One of the very important digestive enzymes that we have in the stomach is called pepsinogen. We know that pepsinogen, anything that ends in -ogen, is inactive, and pepsinogen is activated by hydrochloric acid, HCl. And hydrochloric acid, the acidity of the stomach is about 2.3, and it's needed to absorb calcium, iron, and B12. And if you play around with the pH with antacids and you raise the pH of the stomach and it becomes alkalinic or basic, you now impair the body's ability to absorb iron, calcium, and B12, which has some negative implications there. Also, hydrochloric acid is bactericidal, which means it keeps the balance of the microbiota and bacteria in the stomach in check. And if you start raising the pH, you get bacterial overgrowth. Bacterial overgrowth is called dysbiosis. So in the GI tract, you've got chemical digestion, which is catabolic breakdown of food. Then there's the absorption of the nutrients through the blood and lymph. And when we talk about lymph, sometimes it's referred to as the lacteals. In the lymph is where we have fat-soluble substances that are being absorbed, like vitamin A, vitamin D, vitamin E, vitamin K, and CoQ10, which is a coenzyme. It's not a vitamin, but CoQ10 is involved. If you look at the metabolic pathway for cholesterol production, if you Google that and look at the cholesterol pathway, you will see that coenzyme Q10 is one of the things that's produced in that same pathway. So when people use statin drugs, they use a statin. Statin drugs inhibit or block an enzyme that's called HMG-CoA reductase. HMG-CoA reductase. Anything that ends in ase is an enzyme. When you block HMG-CoA reductase by using a statin like simvastatin, Crestor, Lipitor, any of these anti-lipidemic drugs or drugs used to lower cholesterol, it's blocking HMG-CoA reductase in the liver, so the liver can't produce cholesterol anymore. If it's not producing cholesterol, you're not producing CoQ10. Where is CoQ10 needed? Remember when we talked about the cell, there's a part of the cell that's called the mitochondria, the powerhouse of the cell that makes ATP. The CoQ10 is used by the mitochondria not in the Krebs cycle, but in the stage that comes after the Krebs cycle called the electron transport chain. The Krebs cycle does take place in the mitochondria, but the Krebs cycle is making coenzymes that are needed by the electron transport chain, and those coenzymes are called NAD, NAD, and FAD. FAD. The NAD comes from niacin, and the FAD comes from riboflavin, the F for flavonoid. Niacin is B3, and riboflavin is B2. So you need your B vitamins for that mitochondria and the Krebs cycle to work, especially B1, B2, B3. There are some minerals involved like magnesium, and of course in that Krebs cycle we need coenzyme Q10 and iron. If you don't have CoQ10 and you don't have iron, ATP production is limited. You become fatigued, no energy. Just think of what happens sometimes when women have their menses and they're losing blood and they're losing iron, and they get fatigued. They don't have enough energy. Or if someone doesn't have enough iron in their body, then they're anemic. And then typically the sign of anemia is they don't have enough energy. Okay. So when we talk about the activities in the digestive tract, it's not just breaking down the food, but after it's broken down, it's absorbed. Remember, it's not you are what you eat, it's you are what you can absorb. And whenever you're not utilizing, you need to defecate and eliminate, detoxify, and clear out. Here's a great picture just showing deglutition, which means swallowing, and one of the key anatomical landmarks that I'd like for you to pay attention to is right here in the epiglottis. Okay, here's the trachea, there's the windpipe, and then right here is the esophagus, where food's going to go down. So we want food going down this way, we don't want food going down this way. So this epiglottis is going to close off the airway. It's going to fold down as the food comes down, closing off the airway, so food is forced down the esophagus. You can see that happening. You can see right here, you can see the epiglottis. That's elastic cartilage. That is elastic cartilage, and it's folding down. Here's the uvula. That is innervated by cranial nerve 9, which is involved with the gag reflex. And cranial nerve 9 is also involved with the taste of bitter to the posterior posterior 1/3 of the stomach. Sorry, the posterior 1/3 of the tongue is bitter. The anterior 2/3 of the tongue is for sweet, sour, and salty, cranial nerve 7. Here's the bolus. You can see the bolus of food. And once it hits the stomach, now the bolus is called chyme. Here is the lower esophageal sphincter, also known as the cardiac sphincter. The contractions are called peristaltic contractions, which is the smooth muscle contraction of the esophagus and also of the intestines. Here again is the lower esophageal sphincter or cardiac sphincter that's dumping the bolus into the stomach, and now it's called chyme. Let's talk about different layers of the GI tract. The GI tract we call a tube within a tube. Although the digestive tract is within the body, it's a tube in a tube. That food doesn't become part of you just because you've eaten it. It's got to be catabolized, broken down, and absorbed. It doesn't become you until it gets into circulation and broken down and delivered into the tissues. It's not just you are what you eat, because your kid can swallow a marble, can swallow a quarter. It's in the body, it's in the digestive tract, but within a day or two they poop it out. It's got to be absorbed. So we're going to talk about the primary layers, the serosa, muscularis, the submucosa, and mucosa. And no better way than to show these by looking at a really nice illustration showing these areas. When we look at let's start here at the mucosa, which is the innermost layer, right? So food is going in here. This plica circularis is an extremely important part of the intestine. If you look at it, it's these grooves. They're like spiral. It looks like the inside like a screw in a nut, right? It's this spiral centrifugic type of structure, so that as food is going through here, it's churning and mixing, so that the digestive enzymes, whatever's on the inside, can move to the outside, and what's on the outside can mix into the inside. It's those grooves that kind of churn and mix that food so there's a nice even distribution of all the digestive enzymes. Very important, plica circularis. So the mucosa is really that innermost lining where the food is in contact with the intestine, and it is epithelium. And the epithelium is held together. Remember, epithelium is a bunch of cells held tightly together from tight junctions. When those tight junctions get damaged, you end up with this leaky gut or intestinal permeability. And when the lining of the gut becomes permeable, proteins can kind of leak from the lumen of the mucosa and get into circulation. And when you have these proteins slipping through the leaky gut or through the permeable intestine, it upregulates the immune system, and antibodies attack that antigen of that large protein that's now in systemic circulation. And it attacks the vibration of that foreign protein and anything that resembles it. And intestinal permeability is one of the known triggers for like rheumatoid arthritis and Hashimoto's, a lot of fibromyalgia cases. Another important part of the mucosa is the lamina propria, and you'll see why that's important in just a minute. There's the submucosa. There's the muscularis. And then the outermost layer is the serosa, also known as the peritoneum. Here again is just another illustration. I like this, this view. Let's take a look again. Here is the mucosa, the innermost lining. We know that it's epithelium. Here's the lamina propria, which is an important area. And when you look at the lamina propria, there is a lot of the important parts of the immune system lie in that lamina propria. One of them is called MALT, if we look here. And MALT stands for mucosal associated lymphatic tissue. About 80% of your immune system lies within the gut, within the intestines, and for good reason, because you're inviting foreign stuff from the outside world into your body. And your body has to determine whether or not those proteins are good or bad for you. If the vibration of it is good, you have harmony. If it's bad, your immune system is upregulated, you're going to make antibodies, and it's going to attack it. So there's the MALT. Then we have the submucosa. Then there's the muscularis that is made up of longitudinal and circular muscles. That's going to help to propel food and move it through the GI tract. And then the outer layer is serosa. That's a combination of both epithelium and connective tissue. So as those foods are broken down, they find a way into the arteries. They find a way into the veins. So and they will also find a way into the lymph or the lacteal system. So when the nutrients are carried away, they're going into the veins. In order to make these muscles contract, they need oxygen and energy. That's going to be delivered into the arterial system. So if we look at that outermost layer, the serosa, that is made up of the visceral peritoneum. That's the first layer of the GI tract. It's the outermost membrane. If we look here at this illustration, so here is the alimentary canal, and you can see, so if that's the organ, if this is one of the organs here, then the layer that's contacting that is the visceral layer. That's the visceral peritoneum. On the outside, that's the parietal peritoneum. Okay. And you can see that all of the organs are surrounded by these tissues. You can see certain areas We can see it's called a mesentery. Other parts, they're called a lesser or greater omentum. But there is this matrix that surrounds the entire GI tract. The muscularis, that's the second layer of the digestive tract, mostly smooth muscle. Remember, we talk about muscle, there's smooth muscle, skeletal muscle, and cardiac muscle. The smooth muscle here is going to create these rhythmic segmental muscular contractions called peristalsis or peristaltic contractions. And it's going to help to propel and move the food throughout the rest of the GI tract. That's peristaltic contractions. Submucosa, that's the third layer of the GI tract, mostly connective tissue, and it functions to connect or anchor the mucosa to the musculosa. The mucosa, that's the fourth, the innermost lining or layer of the GI tract, and that's where most of digestion and absorption takes place. We already spoke a little bit about the food allergies in terms of internal versus external environment. I already mentioned that nothing really is part of your system until it's absorbed. It's not you are what you eat, it's you are what you can digest and absorb and assimilate. So when we talk about the oral cavity, we have to mention the lips, the teeth, the soft palate and hard palate, uvula, tongue, and salivary glands. When we look at the teeth, we'll look at different parts of the teeth, but there are 32 teeth in entirety, and it's these here in the front. You've got these sharp ones here and here and here, right? You've got about 32 teeth, and 8 of them, or 25% of them, let's say 25%, if they could rip into flesh, those are the ones that still could. They're a little bit dull, they're not as sharp, but we have had siblings that bite other siblings and they have broken the skin. So, you know, if they were a little bit sharper, I mean, this is the stuff that can bite into cooked chicken and stuff. So you're looking at 25% are designed to bite into flesh, and then the other 75% are designed to grind, fruits, nuts, and seeds. So this is interesting because it helps to understand the different types of foods that we should be eating. And again, look, there are people that are on a ketogenic diet, and there's people on a Mediterranean diet, a Paleolithic diet, and fruitarian diet, and pescatarian diet, and Atkins diet. There's so many. I've heard them all, and everyone claims that theirs is the best, and everyone should be on their diet for their reasons. And if it works for that individual, they found something that works great for their biochemistry. There isn't the perfect way that the entire human species should be eating. There's so many different theories that are out there trying to push an agenda. And I happen to teach with a great physician, a naturopathic doctor, Dr. Diadamo, over at the University of Bridgeport, who wrote a book, a great book, Eat According to Your Blood Type. And based on his theory, he believes if you're a type O or you're a type A or a B, that you should be eating certain types of meats and drinking certain types of fluids. And that his theory in his whole book, if you look at type A's and B's and AB's and O's, he breaks it down into there are beneficial meats that each type should be eating, or beneficial fruits and vegetables and beverages. There are certain blood types that should be more carnivore, and certain blood types that are more herbivore, and certain blood types that are more omnivore, that could go both. So if you have interest, you can certainly explore that theory. But there's something called pH, and we know the pH scale goes 0 to 14, and in the middle is 7. And anything from this point to about here is an acid, and anything from this point to here is a base or an alkaline. And the blood pH is somewhere around here, which is about 7.35 to 7.45. Let's average it out to about 7.4. And your stomach pH is around here, which is like 2.3 pH. every tissue of the body has its own pH. Now, if you're eating colorful foods like red, orange, yellow, green, blue, indigo, violet, those foods will keep you somewhere in the alkaline area. And if you're eating more whites and blacks like foods and dairy and cheese and sugar and salt and white meat and dark meat, those will keep you somewhere in the acidic environment. Now, you'd think that if you had about 50% acid forming foods and 50% alkaline forming foods, that would keep you somewhere in the middle, neutral pH, but it's not the case. Research shows that if you consumed 80% of alkaline forming foods, not alkaline foods, there's a difference, alkaline forming foods, meaning the foods could be acidic on the outside, but what it does in the body is very, very different. So if you consume 80% alkaline forming foods and 20% acid forming foods, about that ratio, that's enough to keep you right around that slightly alkaline, neutral to slightly alkaline environment. Now, my point to that is if you look at that 20-80 split, that's pretty darn close to 25-75, meaning 25% using your fangs for meat and animal-based products and 75% for the Roy G. Biv, Roy, red, orange, yellow, green, blue, indigo, violet foods. Pretty neat, right? How those ratios work. I just wanted to show you this dissection picture because it shows you how big the tongue is. I mean, look at that inside the oral cavity. It does take up a lot of space in there. Here's the cerebellum. Here is your pons. Here's your medulla. And right around here is your hypothalamus, which really starts your digestion and kind of works with the autonomic nervous system of sympathetic and parasympathetic. And then right around there would be like your pituitary. The lips are skeletal muscle. We know you've got the orbicularis oris, that's there. Here's the orbicularis oris, skeletal muscle. And the external surface of the lips is dry, pigmented skin. And the internal surface of the lips is covered by mucous membranes. The function of the lips is to seal the oral cavity and manipulate the food while it's in the mouth. And there's lots of nerve endings there. There is numerous sensory nerve endings. So you can kind of feel, is food hot? Is it cold? And also the lips are involved with speech. And one of the things that's important to discuss when we talk about the lips, we have to consider like a hair lip or cleft palate. And in certain individuals who have a SNP, a single nuclear polymorphism, called MTHFR, it stands for methyl tetrahydrofolate reductase. ACE is an enzyme. There's a large percentage of the population that have a SNP, a single nuclear polymorphism, to methylene tetrahydrofolate reductase. And the two, let's see if I can remember, it's the A1298C, or it's the C677T. These are the two alleles that you would test for mutations. And either if both alleles are affected, then you're homozygous. And if only one allele of the two is affected, then you're heterozygous. And if you're C677T homozygous, very strong indication that there's going to be neural tube defects. that things aren't going to close, like the lips aren't going to form a seal and close, the spinal cord doesn't close, you get these spina bifidas or meningomyloseals, and really it's a methylene tetrahydrofolate reductase. This enzyme is needed to convert folic acid or tetrahydrofolate into its bioavailable form called methyl tetrahydrofolate, the MTHF. And in order to get really to get 5-methyl tetrahydrofolate, you need the methyl tetrahydrofolate reductase enzyme to make it. But there's a lot of people that don't have the enzyme to make it. And those people have infertility issues, they have depression, anxiety, and panic attacks, and spina bifida, meningomyloseals, and bipolar, and ADD, and autistic spectral disorders, and high blood pressure, and infertility, and the list goes on and on and on. Very, very common SNP these days. Diseases of the lips, let's take a look. Herpes, the oral herpes, that's a biggie. Let's take a look. One of the things to keep in mind is no matter what, whether it's a bacterial issue or a viral issue, please remember that they're all opportunistic, and this is what everyone forgets. I don't care if it's the flu, influenza, HIV. The issue here is that every virus is opportunistic, meaning they are looking for the opportunity to spread. And in order to have the opportunity, they need a weak host. It's not just being exposed to the virus that's a problem. Just because you're around someone that's sick doesn't mean that you're going to get the sickness. You have to be a weak host. If you're a weak host because your immune system is compromised, then there's an opportunity for that bacteria or virus to grow. In order to have a weakened system, a weakened immune system, there has to be some sort of neurological compromise to your system. If your neural system is compromised, the signals between the brain and the body, some sort of subluxation, some neurological weakness or disconnect between the brain and the body, then the other system, like the immune system, has to be compromised, and the endocrine system has to be compromised. So keep that in mind. Just because you're exposed to it doesn't mean you're going to get it, unless your immune system is compromised, then there's the opportunity. So with herpes simplex, the gift that keeps on giving, typically this shows up with blisters around the lips, and the cause is the herpes simplex 1 and 2. And there are certain things that can be done to offset this. One of the things is high-dose L-lysine. I would suggest not even 1,000 milligrams, but usually the dosage we use now is more like 3,000 milligrams of L-lysine. And L-lysine competes with an amino acid called arginine. And the herpes virus loves to thrive on arginine. So arginine is required for the herpes virus to thrive, but lysine competes with it. So if we increase the amount of lysine in the system using that amino acid L-lysine and some vitamin C, beautiful. A lot of people take high-dose vitamin C, like 1,000 milligrams a day. Research shows that less vitamin C more frequently is better. So although you can probably take 1,000 milligrams in a capsule, research shows it's more like no more than 500 at a serving is best. You can absorb about 90% of a 500 milligram dose. There's oral herpes. You can see it around the lips there. Lip cancer. Most of these cancers are simply an abnormal growth of epithelial tissue. An accelerated growth of epithelial tissue is cancer. Whether it's abnormal epithelial growth of the esophagus, of the stomach, of the intestines, that's going to be cancer. One of the common causes of lip cancer is going to be smoking. You're going to see smoking in just about every single form of cancer. Um, we can't really think of any good effects of smoking, like, hey, you should smoke because it's really good for you for this reason. It doesn't really exist. So, radiation and chemotherapy, these are poisons, and they're designed to attack and kill these rapidly multiplying cells. And cancer cells are rapidly multiplying, and the radiation and chemo is designed to kill those cells. Although the therapies attack the fast-growing tissues of the tumor, they also attack the healthy tissues. So the whole philosophy and theory is that they hope to kill the cancerous cells and most of them, and sparing as many healthy cells as possible to kind of kill the cancer cells without killing the individual. That's the whole idea. Can we save the individual by preventing those cancerous cells to metastasize, which means to spread to other parts of the body? Here's lip cancer. You can also see the inflammation and the tar buildup. This is a smoker. You can see all the black necrotic tissue here. You can see the mercury fillings. You can see all the tar buildup. All the tar buildup around the teeth. So let's look at the different parts of the teeth. You should be familiar with these terms for lecture and lab. The enamel, the dentin, the root canal, crown, root, gingiva, cementum, and the periodontal ligament. Let's take a look at some of these landmarks. Let me bring this up here. Good. So the enamel, this is the hardest substance of the body, and that's the most superficial and outer part. The part that's above the gum is called the crown. The part that's just beneath the beginning of the gum is the neck, and everything else below that is now the root. And that's where that term root canal comes from. That's this canal, this cavity here, in which you're going to see blood vessels and nerves. You can see within that canal in a dilated part they call the pulp cavity, which also contains the blood vessels and nerves. Dentin, or dentin tubules, these lines here. And when there's a cavity, it's when there's a hole that goes through these dentin tubules. And when that hole goes deep enough and you hit that pulp cavity, that's where you eat something cold or sweet, and it kind of penetrates through, hits the nerve, and then you have the pain. When it's severe enough, they'll have to do a root canal if they can't save the tooth. They'll come in here and just drill all of this out to kill the tooth, so there's no sensation at all. The cementum is the ligament. The cementum is like cement that holds that tooth in, and the periodontal ligament gives the tooth a little wiggle room so the tooth can move and not crack every time you bite into something. And the gingiva is the gum. Same structures here. You can see that we have the enamel, the hardest surface of the body. You have the crown, the neck, and the root. There's the pulp cavity. Pulp cavity contains the arteries and the nerves and the veins. You can see the dentin, which also would then have the dentin tubules. This coming this way. Here's the gingiva, or the gum. Cementum is the cement that holds the tooth, and then there's the periodontal ligament, gives it a little wiggle room, and it sits in the alveolar bone, either the mandible or the maxilla. These are some of the names of the teeth that you should be familiar with. You have the central incisors, just lateral to them. You've got a lateral incisor. Lateral to that is the canine. And then you have your first premolar or bicuspid. And then you have your second premolar. And then you have here your first molar, second molar, and your wisdom tooth, third molar. A cavity is known as a dental carie, and the oral cavity contains so many different types of microorganisms in it, And there's good bacteria and there's bad bacteria, just like in the stomach and the intestines. And the bacteria assist the body in preventing many infections of the mouth, like yeast and thrush. And the bacteria, however, metabolizes the food residue, like sucrose on your teeth, which is sugar, and produces lactic acid as a waste product. And that acid can demineralize your teeth, which can cause a cavity. And the therapy is now the dentist is going to drill out the decayed part of the tooth, and they'll try and pack it with a filling. Hopefully not one that contains mercury these days. So many of the silver fillings contain a lot of metals, nickel and mercury and silver. And nickel and mercury are very, very neurotoxic and can cause many neurological symptoms in many people. You can see the fillings here. I mean, right here, you can see this area of radiolucency. That black shadow is radiolucent. Here's another radiolucent area. These bright white spots, those are where there's already fillings. These are fillings. Here you can see like a wisdom tooth. This one here, that's a wisdom tooth that's starting to get impacted. It's actually rubbing up against that tooth there. So the root canal, when cavities extend through the tooth and they reach the root canal, the teeth have been filled extensively. They'll weaken and then they'll crack. And then you start to get this pyogenic bacteria or staph or strep, and it starts to enter the root canal of the tooth, and it starts to cause pus and infection or abscess, and pressure really starts to build up around that area. So the root canal is when there is the sensitivity to eating hot things and pressure. When you bite into something, the pressure really, really hurts. So they'll have to see a special dentist, an endodontist. They'll grind down the tooth. They'll remove the nerve. And once the nerve has been removed, then the tooth is dead. And they can pack the tooth with this packing material called gutta percha. And then they can insert a post, typically a gold post in the tooth, and then they will cap off the tooth. Sometimes when there are these bacteria, especially strep bacteria, that's found in the mouth, it can spread through the root canal. And unfortunately, in certain individuals who are susceptible, it can actually attack the valves of the heart, causing an endocarditis. And you can see where that arrow is, which is now attacking the heart's ability to open and close the valves. And that's why in many instances, sometimes when there's individuals that have root canal and have surgery, they'll put them prophylactically on antibiotics. Not everyone, but even if they do dental hygienist and they're scraping and they're removing a lot of plaque and they start bleeding, depending on the overall health history of the individual, sometimes they'll give antibiotics. Let's talk about plaque. Plaque or tartar, that's the substance produced by the bacteria which prevents the removal of bacteria from the tooth. So the bacteria that produces the bacteria are referred to as Streptococcus mutans. And Streptococcus mutans produces an enzyme called dextran sucrase. And sucrase takes sucrose and converts it into dextran. And plaque can irritate the gums, and it can cause gingivitis, and the gum line can then recede. Now, dextran, that's the foundation of plaque. It's very sticky, and it can cause a lot of other substances to adhere to it. Other bacteria, debris, other food residues, and particles of smoke. And so, plaque removal is often what the dental hygienist will do using either a Cavitron or a hook, which scrapes the teeth, or an abrasive dentifrice, which is really what toothpaste is. There's plaque. These are healthy gums. Those are inflamed gums, seen with gingivitis. And now the functions of the teeth are involved with swallowing. It facilitates swallowing. It decreases the size of the food. It increases the surface area. And when you chew food hard enough and well enough, at least 100 times, or so you can no longer identify what's in your mouth, you increase the surface area so that all the digestive enzymes can work on that. And it breaks down the cell walls of the plant foods in order to release their nutrients. So if we look at, let's say, garlic, when you bite into garlic, it threatens that part of that food and it releases alicillin, which is a very strong enzyme that's it's a killer. It's really strong. Alicillin sounds like penicillin, and it's bactericidal, it's antiparasitic, it's antimicrobial, very strong stuff. The hard palate is the anterior part of the roof of the mouth, and it's composed of bone, and it helps supports the mouth for chewing. Cleft palate that we spoke about with MTHFR, it occurs in about 1 in 1,500 babies, in where the moms were not smokers, and about half of that, 1 in 700, where the moms were smoking. There's cleft palate, also seen with MTHFR. Cancers of the palate, again, accelerated growth of abnormal epithelial tissue. Symptoms are a painless ulcer. Not painful, but painless. And again, what are the causes? Smoking, tobacco chewing, eating foods at very extreme hot temperatures, and even poorly fitted dentures. The soft palate, it's the posterior part of the roof of the mouth, and that's mostly smooth muscle and some mucous membranes, and it's flexible and also facilitates swallowing. The uvula, which is that flap of tissue that extends down, that's innervated by cranial nerve 9 and 10. So there's a little bit of a mistake there. I don't want it to say 11. It's really cranial nerve 9 and 10. 9 is for the sensation that something has touched the uvula, and then 10 creates the muscular contraction. So 9 and 10 are involved with the gag reflex. 9 for sensory, 10 for motor movement. When someone says, ah, right, they open their mouth, they go, ah, that uvula should rise evenly in the center. If the uvula deviates, then there's cranial nerve 10 damage, usually secondary to a stroke. Cranial nerve 9 and 10, those cranial nerves originate in the medulla oblongata. The tongue, which is a large muscular organ in the cavity, it's skeletal muscle. We know that there are specialized nerve endings and chemoreceptors there. We know that cranial nerve 7 and 9, 7 is facial nerve, sweet, sour, and salty, for the anterior 2/3 of the tongue. Cranial nerve 9, which is the glossopharyngeal, is the posterior 1/3 of the tongue. We know cranial nerve 12 moves the tongue. We know cranial nerve 5 deals with sensation to the tongue, like pain and temperature. And of course, we have taste buds. And these taste buds can actually be blocked by smoking, especially the tar can block the taste buds. There are actually taste pores. And that's why people that smoke for long periods of time and the tar build up, blocking those pores, smokers have a poor ability to taste, and also a weak ability to smell. The reason why we taste sweets is for carbohydrates. When you're craving something sweet, sometimes the body needs energy. When you're craving something salty, it's the body's way of telling you perhaps needs electrolytes. Sour detects an acidic poison, bitter detects an alkaline poison, and the umami detects the glutamate, which is a protein receptor. Sometimes people say, I'm just craving a steak, I just need a juicy burger. They need protein, maybe they need amino acids, maybe they need neurotransmitters. You can see the taste buds, those arrows on the right-hand side. You can see the taste pore, so what'll happen is tar can accumulate right there. This is the taste bud, but this gets blocked right here, then there's nothing to penetrate in. So let's say the tongue manipulates the food in the mouth, cranial nerve 12, the hypoglossal nerve moves the tongue. The food in the mouth is called bolus. When it hits the stomach, it's called chyme, and it secretes an enzyme known as lingual lipase. Remember, anything that ends in ase is an enzyme. Lipase breaks down lipids. Lipids are fats. They're broken down by lipase. And the tongue is involved with speech. Cancer of the tongue, look at that. We got smoking again, and the cancer of the tongue is nothing more than abnormal growth of epithelial tissue. Again, painless ulcer. These are all pictures of painless ulcers of the tongue, of the epithelium. Look at those bottom pictures. You can see the mercury, you can see the fillings, you can see the ulcers, you can see the corroded teeth. You know, teeth are really important. When we do our physical examinations, we always ask the patient to say, we look at the tongue, we look at the color of the tongue, we make sure it's pink. We don't want to see white coat on top of the tongue. We don't want to see scalloping on the side of the tongue, meaning when we see the scalloping, we think that there's food allergies because the tongue is getting a little bit larger, fitting closely against the teeth, and the scalloping is the indentation of the teeth on the perimeter of the tongue. We don't want to see a geographic tongue, or fissures down the center of the tongue, or a strawberry tongue. We also want to see healthy teeth. We don't want to see inflamed gums. The teeth are a really good representation of overall health of an individual. Rotten teeth is a rotten body. Healthy teeth and a healthy mouth is a healthy body. These are rules. These aren't theories. These are rules. When there is a healthy mouth, which is part of the GI tract, you have a healthy individual. The salivary glands, we've got a few of them. Let's see if we have a picture here. Yep, so you can see the parotid gland near the ear. You can see the sublingual under the tongue, and under the mandible, the submandibular gland. The parotid gland is located anterior and inferior to the ears. And we have the submandibular and the salivary glands. So the function of these salivary glands, they're producing quite a bit of saliva. Look at 1,000 to 1,500 milliliters of saliva per day. What's in saliva? There's some water, there's mucus, there's ptyalin with that silent P, or salivary amylase, which is needed to break down starch. There's antibodies in there, control the growth of microbial overgrowth. Using antiseptic, a lot of people use this mouthwash. Horrible to use, really, really bad to use it. You're killing all the bacteria in the mouth, good and bad. So you have to be very careful with those antiseptic mouthwashes. They actually make like a swish swash type of, and a toothpaste that's like prebiotic that actually is putting good bacteria into the mouth. A little bit expensive, but worth it. Sodium bicarbonate is produced, which neutralizes the stomach acid. Again, you can have cancer of the salivary glands, which is, again, an abnormal epithelial tissue overgrowth. And again, the painless unilateral enlargement. Typically idiopathic, meaning no known cause. Let me show you what a cellulitis is. Now, you've heard of kidney stones, you've heard of gallstones. Now, here is a calcium oxalate or uric acid crystal buildup in the ducts of the parotid gland. And it's painful, it's unilateral, and you'll have an enlargement of one side of the cheek. Now, let me just show you where that is in this x-ray. I have had one patient with this, and here it is. There's the cellulitis. And pulling it out of the cheek, right there. See that stone? That's it. And that was about the size of it. Other disease of the salivary glands, there's mumps, a viral infection of the parotid gland. Symptoms are bilateral, painful enlargement of the glands, usually fever and sore throat. That's what it looks like. See the swelling on the side of the face. The esophagus, that's a long, muscular, collapsible tube. It's posterior to the trachea, and it connects the pharynx to the stomach. Here is the lower esophageal sphincter, right there, also known as the cardiac sphincter. Here's the bolus moving down the esophagus. Once it's in the stomach, it's called chyme. These grooves that you see here, all of these little indentations in the stomach, those are called rugae of the stomach. Esophagus is about 10 inches long, and it's just long enough to give kind of time for whatever. If it's hot, food that's hot, it gives it time to cool off before it hits the stomach, and if it's cool, it gives it a time to warm up to body temperature. The esophagus goes through the diaphragm in order for it to get into the stomach. Okay. The esophagus is stratified squamous epithelium. When you look at the top layers here, from about here to here, from here to here, we can see that it's many, many layers, so it's stratified, and these are flat, irregular cells, so stratified squamous epithelium. The functions of the stomach is going to transport the ingested material from the pharynx to the stomach, and it's involved with the equalizing temperature of the food, whatever's going from the mouth into the stomach. In terms of GERD, gastroesophageal reflux disease, this is heartburn. So here, if that valve, the lower esophageal sphincter, is loose or it's weak due to coffee, due to chocolate, smoking, stress, all of those things can actually weaken that muscle of that cardiac valve, so you get the splashing of whatever acids, even it's a normal amount, kind of splashes upward into the lower esophagus. Okay, so here it talks about the incompetent cardiac valve. So when the bolus of food is swallowed and travels down the esophagus and it enters the stomach through the lower esophageal sphincter or cardiac valve, once the food has entered the stomach secretes gastric juice in the food, and it converts into this substance called chyme. Chyme consists of everything that you've eaten plus all the digestive enzymes that are there. As the stomach muscles contract and mix the chyme with the gastric secretions, it's important for the cardiac valve to close. Otherwise, you get the splashing of all the hydrochloric acid from the stomach back up the esophagus, and that's what the reflux is, or that heartburn, or the burning sensation. So what affects the tone of the cardiac sphincter or lower esophageal sphincter is stress and smoking and alcohol and too much coffee and chocolate and obesity and fatty foods. All of that. So gastroesophageal reflux disease can be helped through a variety of methods, one of which is chiropractic care. We have acupuncture, stress reduction, nutrition. All of these things can help. If people have GERD, typically what's helpful is taking the head of the bed, and propping it up higher than the feet. Try and keep the fluids and the liquid moving downward instead of upward. Barrett's esophagus, or Barrett's metaplasia. Metaplasia is a term that means you have one type of tissue type and it's changing into something else. Whenever you have one tissue type that's altered and it becomes something else, that metaplasia is considered to be precancerous. So typically in the esophagus, the normal cells are stratified squamous cells. But if the lining of the esophagus burns away due to the GERD, it's replaced by columnar epithelium. And the columnar epithelium is what we have in certain parts of the stomach. So when you have stomach cells moving up into the esophagus, that is metaplasia. That's called a Barrett's esophagus, and these people have a higher incidence of developing esophageal cancer. The accelerated growth of abnormal epithelium tissue in the esophagus, that is cancer of the esophagus. Cancer is usually squamous cell carcinoma, or it's called adenocarcinoma. Cancer of the esophagus is a rare form of cancer. 20,000 cases a year is typically reported. When you have cancer of the esophagus, you can see that the lumen is being obstructed because you have this abnormal growth of epithelium. What's left of the opening of the esophagus is this space here. So it's difficult to swallow certain liquids after a while, to swallow food, and it becomes real challenging for the individual. The causes of cancer of the esophagus: smoking, nitrates, nitrites, spicy foods, pickled foods, fried foods, smoked foods, environmental toxins, gastroesophageal reflux disease, deficiency in nutrients like vitamin A, zinc, and molybdenum can all cause esophageal cancer. Now, what some of the symptoms are, there's a little typo here. Instead of dysphagia, spelt like this, we're going to make that S a G. Dysphagia with a G. With the S, it means like difficulty in speaking. With the G, it's difficulty in swallowing. So dysphagia with a G, begins with dry foods, bread and crackers, and then it progresses to more solid foods like meats, and then finally liquids, and it becomes difficult for them to eat at all. Typically with esophageal cancer, they'll experience the acid reflux. They'll have substernal pain just behind the sternum, and also they have back pain. And if for cancer, they're going to do surgery, they're going to do radiation, chemo. When you look at the different layers of the stomach, you can see we have different layers of muscle. When you look at this layer is the longitudinal muscle layer, there's the circular layer, and then there's the oblique layer. These three layers of muscle can contract. When digestive enzymes are too little in the stomach, those muscles contract hard, and along with the rugae, these rugae don't just allow the stomach to expand, but these grooves are designed to kind of grind the food like secondary teeth, especially when those three muscles contract. But when they contract hard and that sphincter is open, those acids splash upward into the esophagus, causing GERD. Here's the cardia. Here's the fundus of the stomach. The lower esophageal sphincter or cardiac sphincter would be right about there. Here's the pyloric sphincter. And then the beginning of the small intestine called the duodenum. This portion here is called the lesser curvature of the stomach. That's this concavity here, the smaller part, and the larger part on the to the right. That larger curvature is called the greater curvature of the stomach. The stomach is a J-shaped organ. You can see it there. And again, it is the three layers of smooth muscle: the longitudinal layer, circular layer, and oblique layer. We showed you the rugae, which gives the stomach a little bit room to expand. There's a good picture of the rugae of the stomach. And let's talk a little bit about the pits, the gastric glands and pits. Really important to understand what these cells are. We have chief cells. Chief cells secrete pepsinogen. There's the O-gin, which means it's inactive, and we need something to knock off the O-gin to give us pepsin, which is the primary digestive enzyme to break down protein. What's needed for that is this, hydrochloric acid. Where does the hydrochloric acid come from? Parietal cells. So the hydrochloric acid that's made by the parietal cells knocks off the ogen and gives us pepsin, which is the primary digestive enzyme to break down proteins. Parietal cells don't only make HCl, which is hydrochloric acid, they also make intrinsic factor. What's intrinsic factor needed for? Intrinsic factor binds with B12. B12 is cobalamin. Cobalamin comes in different forms, cyanocobalamin, methylcobalamin, acetylcobalamin in the supplemental form. Intrinsic factor binds to B12 only in an acidic environment, which means we need the hydrochloric acid. So if someone takes Pepsid AC or Acidex or any type of antacid, which will increase the pH of the stomach, when you increase the pH, you're going from an acid to an alkaline, you don't get B12 absorption. You don't get calcium absorption, iron absorption, calcium absorption, B12 absorption. It doesn't happen. And you get bacterial overgrowth. So the natural pH of the stomach due to hydrochloric acid is about 2.3. 2.3 pH. That's acidic. These are the gastric pits, and we can see down here the different cells. So here's the parietal cell that makes the hydrochloric acid and intrinsic factor. Then we have the chief cells that makes the pepsinogen that needs to be converted to pepsin. The hydrochloric acid that the parietal cell makes goes to the hydrochloric acid. The parietal cells that make the hydrochloric acid affects the pepsinogen that the chief cells make and gives us pepsin. Here are the mucus cells. The mucus cells are stimulated by the prostaglandins. Prostaglandins tell these mucus cells to produce mucus, and it lines the stomach. It protects it against all the acid. Okay? Okay, let me go back here. Let's just see where we are. Okay. Again, just a really good, a nice illustration that's showing pepsinogen to pepsin. The reason why that happens is the hydrochloric acid that's made by the parietal cells. And the chief cells are what's making the pepsinogen. The hydrochloric acid knocks off the ogen, giving us pepsin. These enteroendocrine cells, really important too. They make histamine, they make CCK, they make serotonin. Really important cells as well. But they make histamine. So when you consume foods that you're allergic to, the enteroendocrine cells make histamine. And histamine affects your sinuses, they affect your skin, they affect your bronchi, so you can get sinus congestion, you can get hives, you can get itchy. It affects the bowel, you can get diarrhea. So the mucus cells secrete mucus to protect the lining of the stomach. Parietal cells secrete HCl and intrinsic factor. We already spoke about the chief cells. We spoke about the enteroendocrine cells producing serotonin. Now, serotonin is a neurotransmitter, but the intestines have more receptors for this neurotransmitter in the stomach than the brain has. Enteroendocrine cells produce CCK. Remember, CCK goes from the duodenum to the gallbladder, makes the gallbladder contract, pushing out bile, phospholipids, toxins, cholesterol. Okay. The stomach lining, as people get older, the stomach lining thins. Keep in mind the people that are having a stomach surgery to make the stomach a little bit smaller certainly affects their iron absorption, B12 absorption, their calcium absorption, B12 absorption, bacterial overgrowth. So you have to be real careful with these procedures, although sometimes they are medically necessary. Just have to nutritionally monitor these people. The stomach does not digest itself because of that thick bicarbonate-rich mucus, that alkaline mucus coating. Epithelial cells are joined by tight junctions. Again, if those tight junctions are damaged from steroids or NSAIDs or alcohol and too much coffee and refined carbohydrates and antibiotics, then the tight junctions become leaky and you get that leaky gut or intestinal permeability. Okay, so that's going to finish the first PowerPoints, and we'll do the second set shortly.